minutes
Recording
coming
in
up, and I'm looking
progress.
forward to all three of our speakers. And I will first introduce Dr. Bethany Het-Gauthier. Dr. Het-Gauthier is a biostatistician specializing in health systems and implementation science research in sub-Saharan Africa. She is an associate professor of global health and social medicine at Harvard Medical School and of biostatistics at the Harvard Chan School of Public Health. And she is the director of research in the program of global surgery and social change. Dr. Het-Gauthier.
Great, thank you so much. And let me just get queued up here. Can you see slides? Great. So I really appreciate Dr. Hunto and to your team the invitation. This is a unique lens to look at global surgery, and so I'm excited to explore this with you and with my co-panelists. And Dr. Always a pleasure to be in events with you, and thank you for the kind introduction. I'm going to set the stage for the conversation tonight, really thinking about why we're in this space, and should we be here, and how do we operate in this context. So just as a bit of a background, the Lancet Commission in Global Surgery that Dr. Hunter referred to, and Dr. Muir was a co-chair of, was really some seminal work in outlining the global needs for surgery. And it was really something that actually brought me to the field. I'm not a surgeon, I'm a health systems researcher, but this commission laid a compelling case for why we need to be paying more attention to the global surgical need more broadly. So just a few highlights of the commission. Probably the biggest highlight, evenly distributed. There are in need of global surgery. There need to be 143 million additional procedures to fill the unmet need for surgery. 81 million people are at financial risk. They would experience catastrophic health expenditures for surgical care every year. So it's not just about providing surgery, it's about providing affordable and accessible surgery to these populations. We need to invest another $350 billion into surgical and anesthesia systems to be able to address these deficits. And then finally, just really making the case that surgery, obstetrics, and anesthesia are just integral parts of the healthcare system. And so we really can't talk about primary healthcare, comprehensive healthcare, universal healthcare without really addressing these deficits that were outlined in the commission. So with that in mind, of course, these are not evenly distributed, these needs. And so this is showing you a graph of the global distributions of surgeons, anesthesiologists, and obstetricians per 100,000. And the target for this is to have at least 20 per 100,000 to really address the deficits that I just outlined. And what you can see here is there are many countries in the world that are exceeding this target of 20 per 100,000. So the top density in this map is 85 per 100,000 in Sweden. And then there are many countries that are far, far below this target of 20. So Rwanda, where much of my work is concentrated, has 0.68 per 100,000, and Sierra Leone has 0.15. And so it's not just about addressing surgical needs everywhere, but it's really about prioritizing populations that have been historically marginalized and finding ways to both address the short-term needs, but also the long-term needs of these systems to be able to provide the surgical services. So clearly there is a need for more global surgery. And so then the question is, do we have a moral obligation to address this need? So are we morally obliged to respond? And I oftentimes think about my moral obligation from just a human rights perspective. So health is a human right. And I provide here a quote from Paul Farmer, who was my department chair and really instrumental in the founding of the program in global surgery and social change that John directs and Dr. Junjwala and Dr. Joseph and I are members of. And for this, just this quote from Paul really brings us home. For me, an area of moral clarity, you're in front of someone who's suffering and you have the tools at your disposal to alleviate that suffering or eradicate it, and you act. So we really are, from a human rights perspective, have a moral obligation to use our skill sets to address the global surgery deficit that's highlighted in the commission. A second platform for moral obligation is thinking about it from our complicity and benefits from systems in which we are complicit. So, the foundation of we are complicit in and benefactors of systems that contribute to the global surgery inequities, and therefore we are morally obliged to try and reduce those deficits. So I wanted to give you a few examples of that. This is a paper that was highlighting the colonial error and how we globally have benefited from the colonization of Africa, and also how we, in that colonization, really undermined health systems that were already in place, and the way that people traditionally accessed care and didn't invest in the infrastructure as we were extracting resources from that infrastructure. So that is a historical complicity from which we benefited from. But there's even modern day examples of this. And so here's an example about how we in the US benefit from how this headline poses it, stealing doctors from other countries. And so when we think about this SAO density and the fact that Rwanda and Sierra Leone are so far from achieving their density targets, we have to recognize that we benefit in our healthcare system from extracting the human resources from many of these countries. So if we feel compelled that we have a moral obligation to address the surgical need, I immediately start thinking, is moral obligation enough to bring me to this space and to keep me in this space? And some of the extreme situations we find ourselves in when we are only compelled by moral obligation. So here's an example of a young American, and it's a very extreme example, but a young American who, in her own words, it was very, very profound feeling and experience. It's kind of hard to even describe in words. It was like something that I was supposed to do. So this is a young American who in Uganda started a medical mission to treat young Ugandan children, and actually under a series of investigations found that her lack of medical knowledge and medical care actually was to the detriment of these children, led to many deaths, and she's currently under many lawsuits because of that. But she felt compelled to do the work. And I would argue in that moral drive probably had blind spots to her own weaknesses of how she might actually be causing more harm than actually trying to benefit the systems she was trying to benefit. So this is a really extreme example. I'm going to just briefly put up one that's really more something that we would see often, and Dr. Junjawala is going to talk to you more about the discussions around the ethics of surgical missions. And I purposely put up mercy ships here as the screenshot example of short-term surgical missions trying to address some of these deficits, because I know one person personally who works for mercy ships who I know is constantly interrogating how he is in the space and the contributions of the mercy ships. So it's not that I think this group is bad. I actually think it's a group that's under evolution, and it's a really exciting evolution to do, but it is a place of discussion, and Dr. Junjawala will take us through that discussion. But are you in mercy ships because of the moral obligation? What are your motivations for being there? Clearly, it has very personal benefits to individuals. So here's an article talking about one of the patients who recovered and received excellent outcomes because of the care through mercy ships. But I'll just put these here, just the revisiting of these surgical trips. And again, the next speaker will speak more about these surgical missions and their contributions and the ethics of them. So I wanted to highlight that Dr. Hanto came to me with a proposal of, lay out the need for global surgery and our moral obligations. And again, I immediately think, well, is moral obligation enough to bring us to the space? And I wanted to highlight some of the strategies that I employ, or that our teams try to employ, to really think about how do we operate in the space in a way that's contributing and truly aligned to our moral obligation, but also not vulnerable to our blind spots. And how do we successfully operate in this space? That pun is intended for the surgical crowd, but I want to give you a few solutions or a few options of how we think about our work. So the first is, even though it's oftentimes uncomfortable, to really interrogate the space. And this is just a slide from two of our surgical fellows, Dr. Aliande and Dr. Miranda, who talk about both the history of colonialism in health systems and just more broadly, and then thinking about how neocolonialism presents itself in global surgery. And they are challenging conversations to have, but having these conversations helps us better see our blind spots and know how we might try to counter those. This is another article I want to point you to that talks a lot about the power relations between the different key players in global surgery and global health, and thinking about how those power relations manifest in this space. And again, understanding those power relations really help us identify our blind spots and counter them. Another second thing we try to do is not just interrogate the space, but interrogate ourselves in the space. So why am I here? And I want to point you to this presentation by Dr. Irihambua, where he talks a lot about our identities. And if we're just going to a community because we want to help solely from moral obligation, that's not enough to really do good work, that we have to have other motivations. You know, how does this benefit me? How does this help my goals? What's the alignment between my professional goals and the communities that I serve? How do I make sure there's better alignment, good communication? These are all things that we need to think about, not just our moral obligation. Another part of interrogating ourselves in this space is thinking about why we do the things that we do. And so these are two papers that I worked on in the last few years. One that highlights how our academic affiliation, so specifically me as Harvard faculty, and the promotion systems within academic affiliations really motivate what I claim to be bad practice. So in a few years, I'll go up for promotion, I'll count the number of first author publications that I have, and that promotional system manifests in the fact that folks who are affiliated with US high profile institutions, their papers are less likely to include colleagues from the countries that research is about. They're less likely to include those colleagues in prominent authorship positions. And so there's evidence of bad collaborative practice that comes from those institutions. And so one of the solutions we put forth is, if we know that that drives less ethical collaboration or less equitable collaboration, then we really need to be addressing those promotion policies and trying to change those pressures so that we can be more equitable and ethical in that approach. The third thing I want to put forward is just adopting very pragmatic strategies to improve the practice of how we occupy the global surgery space. So this is just an example, and it was one of the recommended readings for tonight, of some of the very practical things that our team does to try and make sure that, yes, we know we have blind spots, yes, we know we're under pressures, but how do we try to specifically counteract that? So we do a lot of trainings that are focused on global surgery and global surgery research. We do host PGSCC fellows at our project sites, but we make sure that there's a joint learning plan that benefits both our colleagues in Rwanda for me and our PGSCC fellows. And then we're really thoughtful about mapping out our research space and making sure that there's opportunity for everyone on our team to grow professionally in the work. And that, again, we don't have blind spots of people that we might exclude or not think about for opportunities just because of the historical power dynamics. And then finally, and I think you'll hear this a lot throughout the evening, is just really centering our work for and through our partners. And so, I love the work that I do in the global surgery space, but it is at service to other colleagues, and it's at the direct request of other colleagues, and trying to make sure that I'm addressing their requests and not just motivated by what I think is right, by what I feel compelled to do by my moral obligation. So just in quick summary, just a very brief tour about the needs in global surgery. I do think we have a moral obligation to be addressing these needs in global surgery. I don't think that moral obligation is enough to bring us to this space. And then hopefully some very practical strategies that we can adopt to make sure that we're countering some of our blind spots if we just were to be in the space because of moral obligation. So I look forward to the discussion, and I'm going to hand it back to Dr. Mira for the next speaker.
Dr. Het-Gauthier, thank you so much. That was fantastic. And I certainly have a number of questions, and I know our participants will as well. Just to remind the participants, please, keep your questions, keep them coming. I'm watching the Q&A board here, and after our third speaker, we'll have a chance to answer all those together. So I'd like to introduce our second speaker now, Dr. Michelle Joseph. Dr. Joseph is an academic trauma and orthopedic surgeon. She's an instructor in global health and social medicine at the program in global surgery and social change at Harvard Medical School, and an adjunct associate professor at the University Uniformed Services Walter Reed. At the PGSSC, she holds co-leadership as our Chief Strategy and Health Equity Officer, and she is one of the inaugural recipients of the American College of Surgeons Board of Regents Innovative Grant for DEI and Anti-Racism. Dr. Joseph?
Thank you very much for the introduction. Good evening, good morning, and good afternoon to all of you who are joining us today. It's a pleasure to be able to be part of this panel. I'm excited to share with you some of this information, and especially looking forward to the Q&A that we will have at the end. So I'll get straight into this. Complex surgical procedures. As you've heard from Dr. Het-Gauthier, we have this moral obligation and need to go even beyond that, because the consequences are great when we don't offer and provide the surgical care that is required. When we look at the economics of this, the consequences are great. Publications in global health policy and those specifically related to surgery have modeled 12.3 trillion economic consequence for not providing surgery. The ethics around this have been discussed most recently in a BMJ Global Health publication, focused mainly on the clinical care delivery, which will be the main focus of this talk, but also on the education component, the training components as well associated with the ethical delivery of global surgical care. Partnerships, as you heard from Dr. Het-Gauthier, are terribly important, especially making sure that they are equitable. There is true collaboration, and we're really honing in on the key matters when it comes to appropriate care delivery. So what do we mean by complex? Well, today I'll talk to you about a definition of what complex means in the context of this particular work, the overarching challenges that we face, the challenges in the context of the Beauchamp-Childress framework, but also how it can be adapted to global surgery at large. And then finally, I'll touch on some of the solutions, which we've already heard to some degree. So what is complex surgery? Well, all surgery has a propensity to be complex, and setting really matters, but there are some absolute factors. The surgical procedure itself may require highly specialized surgeons with skills that are rare, surgical equipment or implants that are expensive and not readily available at all centers, anesthetic requirements, not only lengthy surgery, but complex in delivery. And then we have the relative factors, comorbidities. And I call them relative because if you could imagine in a high-income facility in a tertiary center, which is used to having patients who have significant comorbidities, but they are equipped both in resource and skill set in terms of the workforce, they're able to deal with these relatively easily. If you're in a setting where these things are sparse, then suddenly these comorbidities can pose great problems to delivery of surgical care, creating a complex surgical procedure. In addition, adjunct requirements for care delivery, not just the surgical procedure itself, but the post-operative care. And finally, the facility capabilities. So when we think about complex surgery, you don't necessarily need to imagine the complex reconstruction of a hand or a facial trauma or facial deformity, but rather think about it in the context of these factors, absolute and relative. The overarching challenges that we face from the lens of the global surgery practitioner, and by that I'm talking about those of us who reside in high-income countries that refer to it as global surgery, our perception of the challenges, because we do not reside in these spaces day in, day out throughout our careers, is the tip of the iceberg in terms of the knowledge. The delivery of this complex care really requires a good understanding of the root causes, and they can be country specific or region specific, the nuanced complexities that you cannot simply gather the intel on through short-term mission trips, but you're really reliant on those who are living and working in this space on a day in, day out basis. The geopolitical components to the delivery of systems strengthening when it comes to ensuring that surgical care is widely available and we are really reaching that unmet need, and the stability in which this care is attempting to be delivered. If we were to summarize these overarching challenges, there are three main areas I'd like to focus on. The feasibility of the delivery of this care. What is the power paradigm? And that really ties in with the development of the partnerships that we really feel are important for ethical delivery of global surgery and the sustainability of them. So feasibility, we're really thinking here about the resources that are available and the time that is spent. And Dr. Jojimula will go on to talk about the actual pros and cons of the short-term mission trips, but time matters. Time matters from a individual point of care delivery to a systems level. Understanding the barriers and facilitators at both of these levels is key to really acknowledging the feasibility of delivering complex surgery based on the definition I mentioned. And defining who owns the responsibility of the patient's care. If you can imagine the delivery of care for a patient, if you're only there for a short space of time, who picks up the potential complications that may happen? And therefore, your ethical question is, was it wise to do the surgery in the first place? And whose responsibility should it be to pick up those issues should they arise? What are the clinical sequelae? And we'll go on to talk about that a bit more later. In terms of the power paradigm, this is really embedded in the history, the colonial history, but also the neo-colonial as well, and the disconnect between who makes the decisions at the table versus who is actually experiencing the attempt of delivering these complex surgeries on a regular basis. We have to try and redefine this. And when you think about the shift that is required in this power paradigm, what we're really talking about is utilizing this word equity over equality. What we want to see is that those who are making the decisions in this space and really driving what the priorities are need to be those who reside in country and are involved in the delivery of surgical care. And how do we sustain this? How do we just sustain this attempt at delivering feasible complex surgery? It does come down to funding and also independence, so you're not reliant on these short-term missions, and a shift towards systems building and education and long-term partnerships whereby you are building up the expertise in country. Essentially, you want to aim to do yourself out of a job when it comes to the delivery of this healthcare type. So when we think about this in terms of ethical frameworks, one that we're all familiar with are the four principles. And how does this fit into global surgery and what are the challenges? So I'll briefly have this up: autonomy, beneficence, non-maleficence, and justice. And really what we're talking about here is how much do the patients have say in making their decisions. We want them to have that level of autonomy, and this is for all patients. Doing good and promoting that while avoiding harm, maximizing the benefit of patients and society at large. Now, what does this look like in the context of global surgery? Well, there are some issues that we need to talk about. There are certain barriers that suddenly come to the fore. Cultural awareness, language barriers that one may face. Are you truly gaining full consent when attempting to deliver complex surgery in these low to middle income settings? What happens when there is a ambiguity? Do you proceed in life-saving urgent events, or do you stick to the moral obligation of ensuring that the patient is making a fully informed decision? These are challenges that are not fully answered by the framework in its entirety, 4 principles. Looking at beneficence, when we think about global surgery practitioners, so surgeons from HICs going to LMICs, there is always a chance that you may end up working outside of your normal scope of practice. So the ethical question here is, would you want to deliver standard of care that is potentially what you may consider lower than the normal standard of care that you would deliver in your home country? These are really hard questions to answer, particularly when it comes to acute emergencies. One would argue that the scope, you should remain within your scope of practice and maintain a good, high quality standard of care. That would be the ethical code. Challenging when you're in those environments. And who manages the continuity of care? How do you manage follow-up? What are the long-term potential problems? Well, there is always a potential for complications that may occur. The question you should ask yourself is, was it the right choice to make to deliver that surgery, knowing that there may be potential consequences that you will not be around to take care of? In addition, if you're offering high-level surgery that requires adjunct support, HDUs or ITU services, are you exhausting resources from other areas that the facilities may offer in terms of healthcare? How do you balance that real moral ground between delivering to many versus fewer patients without forming these unintended consequences? And finally, the justice component. The ideal scenario is that we offer equitable access to all in need of surgical care. The reality is patients are selected based on the safety, based on the workforce that's available, based on the resources and the location, the facility capabilities. So if we go beyond using these 4 principles and think about things more in a systemic fashion, I mentioned the workforce density issue. The infrastructure is key. Systems may be isolated and not necessarily, there may not be the necessary communication between the tiers of surgical care that will be normally available, or rather in the HIC setting that does not translate to the LMIC setting or the country or region that you are working in. It's important to ensure that there is a full understanding of the systemic challenges before embarking on surgeries that may actually end up doing harm. And finally, as I started the talk, talking regarding the economic factor, there is this ethical and economic obligation to mitigate the economic consequences of not providing surgery. But at the same time, we need to ensure that there's a balance between working within the existing structures. But how do we improve them? So that some innovative work that's been used to tackle this difficult conundrum is to look at the prevention component to this. How do we mitigate surgeries that may not need to happen if we were able to work with civil societies or public health departments and organizations, NGOs who work in the space of prevention? And when I think of prevention, I really hone in on injury prevention, because we know that that is a area that can be prevented with the right mechanisms in place. Standardization of care. Should there be a level of standards of specific procedures that are really governed by bodies within countries? And if that's the case, how are they followed and how are they put into place? It's a challenging proposition, almost one that falls into the realms of ideals. But standardization is important to ensure that there is some degree of protection for patients. The education and programs that are existing in this space are a good, solid mechanism for really building up surgical practice in country. Long-term educational programs really do promote the equity factor, whereby we are ensuring that the skills reside in country and the surgical procedures are performed by those who live and work in these spaces. And finally, partnerships. We've spoken about this already. Dr. Head-Gautier has mentioned this quite clearly, that partnerships are really the key to developing these, doing this work well. And developing ethical frameworks should be centered around these partnerships, having equity, that 80-20 split, as your focus. So in summary, the overarching challenges are vast. When you think about them under the guise of feasibility, the power paradigm, and sustainability, there are mechanisms and metrics for us to really help us be our sort of compass, if you like, in guiding how we approach them. In terms of the key challenges, when we think about the Beauchamp-Ben-Childress framework, consent, when we think about autonomy, the practice and benevolence, and the unintended consequences that can occur because of the will and desire to provide care, which may be out of our scope for practice, normal practice. And thinking about these things housed within the systemic challenges that we face. And finally, the innovation factor. How do we really harness these areas in order to make sure that complex surgery, in terms of the absolute and relative factors, can be delivered and really move towards meeting that unmet need in an ethical way? Thank you for listening.
Thank you so much, Dr. Joseph. Boy, we're going to have a lot of discussion here in just a few minutes. We're getting some good questions from people. Please keep the Q&A coming. I'm keeping track of them. And as soon as we're finished with our third speaker, we'll get to those questions. So now for our third speaker, Dr. Rashi Junjunwala. She is currently a general surgery resident at Beth Israel Deaconess Medical Center. And she has been a Paul Farmer Global Surgery Fellow in the Program in Global Surgery and Social Change for the last 2 years. Now, for her third year, she will be our Chief Fellow in the program. After her Chief Fellow year, she will be completing her residency training in general surgery, and she plans to continue her work in global surgery as a trauma surgeon and an advocate for health equity. And I would also add she has a master's in ethics, so she's well suited for this discussion. Dr. Junjunwala.
Thank you, Dr. Mira, for the kind introduction, and I'm really glad to be here with everybody. Big shoes to fill, but I'm our third speaker for this evening, and I will be talking about whether short-term surgical mission trips still have a role in 2022 and onward. We're just going to start off with a case. So I'll read this kind of briefly, but a 25-year-old American med student who's interested in global health and surgery decides to participate in a global surgery trip at the end of her first year of medical school. So she fundraises all year, and in June, she goes to Haiti for a week-long surgical mission trip. While there, she first assists on 30-ish hernia repairs, hydrocele repairs, and elective cholecystectomies, as well as some emergency cases. She leaves the week with a newfound appreciation of the burden of surgical disease in low and middle income countries, a renewed love for surgery, and she has obtained certain technical skills that she would not acquire during the rest of her time as a medical student in the United States. About 6 months after she returns from the trip, she finds out that one of the patients she operated on died of septic shock after inability to arrange post-op care. So the question is, what is the problem? And what are the problems? So as you've heard from Dr. Hedgelth's talk and also from Dr. Joseph's talk, you're going to hear some themes kind of reiterated, but I think that just speaks to the importance of them. The global burden of surgical disease disproportionately affects people in low-income countries and low and middle-income countries with disproportionate challenges in managing the surgical disease process in these settings as well. So not only is there a lack of timely surgical access in many LMACs, but there's also a catastrophic economic burden if one is even able to access a surgeon or an OR. And many of the reasons for this is because of a global shortage of surgical obstetric and anesthesia providers. So given the immense scale of this problem, we have to ask, as we often ask in surgery, is perfect the enemy of good? So, in an ideal situation, low income and low and middle income countries would train and retain their own surgeons, obstetricians, and anesthesiologists to provide first-class care to their citizens, the same way that we expect in many high-income country settings. So you'll see a list on the left of numerous challenges to this ideal situation, many of which, as have been kind of alluded to in the previous talks, are a result of colonialism and resultant wealth disparities, resources, and education disparities. You'll see this graph to the right of the screen that describes the number of doctors, nurses, and midwives per 100,000 population in each continent with relation to the number of DALYs, or disability adjusted life years, per 100,000 population. And you'll note that over 50% of the world's providers are located in Europe and the Americas, whereas 3% of the world's providers are located in sub-Saharan Africa, which has the highest number of DALYs per population. So notably, you'll notice that the situation is such that there are just not enough providers in places where the burden is very high of surgical disease. So given all of this, do short-term surgical missions provide a temporary, if not imperfect, real-world solution to the problem of inadequate access to immediate surgical care? You heard Dr. Joseph talk about some of the challenges here, and you heard Dr. Hedgelth talk about our moral responsibility. But we sometimes, need to think about it in terms of in a political philosophy approach as well. So if high-income countries are obligated to provide some sort of surgical healthcare to those in LMICs without sufficient training or resources, the question is a short-term surgical mission a reasonable way in which to offset this responsibility with a middle ground of sorts, whereby surgeons can do good and offer some training, provide some concrete life-saving intervention, et cetera, without requiring a complete upheaval of their own life and practice. So while I won't delve completely into the world of political philosophy for this talk, there are many ways in which nations govern their socioeconomic investments. So on one hand, you have countries that rely heavily on a statist approach, which they prioritize care to their own citizen over others and only focus on emergency support for others when needed. However, countries, on the other hand, who rely on a cosmopolitan approach, focus more on a global approach to welfare, emphasizing basic welfare for all, But, how much does this type of investment actually cost? When we talk about equitable distribution of resources, what do we actually mean by that? So the organization, management, and operating costs of short-term surgical missions requires billions of dollars per year. So what is the responsibility of high-income countries that fund and support these missions in offsetting or displacing some of that overhead? And could that money be better spent in education and infrastructure in the areas in which short-term surgical mission trips operate? So this paper gives some sample statistics from 601 respondent physicians, indicating an increasing participation by U.S. physicians in short-term medical missions, including the opportunity cost of lost time when they're not practicing in their home institution or their home country. An average total economic input for an individual physician pursuing a short-term surgical mission for about a week on average exceeds $11,000. So composite expenditures for short-term medical mission deployment from the United States are about $3.7 billion annually. And the resource investment equates with a nearly 5,800 physician full-time equivalents. So that is a lot of money. So given all this money that we're spending on short-term surgical missions, what are the benefits and harms of this model? We've talked about many concepts of benefit and harm, and we have to ask who's benefiting and who's being harmed potentially by these trips. So on the top right-hand side of the slide, you'll see a blurb, which is actually taken straight from a group that sends high-income country participants to medical mission trips. And I won't read the whole thing, but I will just point your attention to the second paragraph, which begins, you can expect medical mission trips to hone your knowledge, skill sets, and problem-solving capabilities. These trips will provide plenty of hands-on clinical experience and train you to deliver maximum care with limited resources. In the end, these trips will make you a better practitioner, reinforce your passion for medicine, and show current and future employers that your boundless capacity for care makes hiring or promoting you an easy decision. Now, that is, in my opinion, a very biased benefit that is focused on entirely on the providers that are coming, parachuting in, if you will, to provide what they believe is care, but also to really gain experience and knowledge at the expense of others. So is participation in a short-term surgical mission a form of neocolonialism without any opportunity for redemption? Or does an all or nothing approach minimize the benefits that a well-run, longitudinal, and enduring short-term surgical mission structure could offer? So the other paper that you see here is a qualitative study of local healthcare providers in Port-au-Prince, Haiti. And in this study, 4 themes emerged. So general perceptions, the perceived effect of these mission trips on the healthcare system, the perceived effect on healthcare workers, and future recommendations. And in general, the study found that local healthcare workers appreciated the skills and knowledge that teams impart, and they improved access to surgical services for the poor. However, volunteers working independently of local teams creates negative perceptions. It stresses out the local healthcare providers and also strains the hospital resources. So not to be a broken record with my fellow panelists, but we really need to be working in collaboration with the teams that we aim to serve so that we can actually identify sustainable solutions. One other systematic review that was published reviewed 1,600 studies, 41 of which met full inclusion criteria. The studies reported a minimum of 6-month follow-up, showing a follow-up rate of 56%, and really notably a complication rate of 22.3%, which I just want to reiterate is an absurdly high number compared to what would be deemed acceptable in many high-income country settings. 15 out of 20 studies reported on follow-up also reported on sustainability characteristics, but the 12 studies that did not report on duration of follow-up rate reported a complication rate of 1.2%, which is kind of not really contextually located. So it's hard to kind of know what that actually means. So in summary, when you think about the harms of a trip like this, you think of lack of investment and buy-in in local infrastructure, creation and setup and maintenance of neocolonial reliance on external funding structures, and then inadequate care potentially that's given by inadequately trained or equipped providers to deal with the patients that they're seeing. So if short-term surgical mission trips are to persist, what requisite standards or guiding principles should we employ as rules for engagement? So this is a set of 7 guiding principles that was actually first introduced in the world of pediatrics in 2007, but I do think that there are many of the themes that we actually focus on in our own work today and also would carry forward. So you need to have, first and foremost, a common and specific sense of purpose in your mission that is based on a collaboration that is truly based on a community and its infrastructure. And as has been mentioned most recently by Dr. Joseph in her speech or her talk, education and cultural competency training for volunteers, as well as strict rules for the scope of practice and emphasis on good communication and goal setting is absolutely crucial. We also need to focus on teamwork and building capacity for ongoing and sustainable interventions. And then finally, monitoring and evaluation frameworks for both short and long-term outcomes, patient safety, schedules, and plans for follow-up care, as well as referral networks to existing hospitals or clinics for post-op emergencies or issues to create actually a comprehensive network of sustainable and long-term care. So if we go back to the first slide of our 25-year-old med student, where could this have been improved? So she fundraises all year, contributing to that $3.7 billion investment that American physicians pour into this endeavor. Could that money have been better spent elsewhere? It's possible. She goes for a week, in which time she hardly has the opportunity to gain any sort of experience or context or develop strong or notable partnerships. She's first assisting on all of these operations, which is not within her scope of practice. She notably does develop a newfound appreciation for the burden of surgical disease in low and middle income countries and comes away with that appreciation, which drives her career in the future. But she also came away with a bunch of technical skills that she probably shouldn't have even been having the opportunity to develop. Most importantly, the patient who died of septic shock due to inability to arrange post-op care, that should not have happened. So, if you think about the answer of whether we should be still doing short-term surgical missions in 2022, it's evident, that the global surgical burden of disease is massive and it continues to grow. And although sustainable capacity building and educational efforts are without a doubt the gold standard to which we should all be striving, I do believe that there is a space for an equitable short-term surgical mission model for care provision as a way to decrease the gap in surgical healthcare needs and healthcare delivery. But if we take on our communal responsibility, our charge is to adapt and improve the imperfect offering that we have with simultaneous focus on building capacity. We must focus both on the now and the future. So short-term surgical missions should be integrated with monitoring and evaluation frameworks, capacity building, and longitudinal training programs, as well as bilateral partnership initiatives. Thank you very much. And I will turn it back to Dr. Mira for the discussion.
Well, Dr. Jhunjhunwala, thank you so much. And thank you to all three of our speakers. That was fantastic. It's a lot to unpack. And I think it's going to take us about 2.5 more hours. So everybody get comfortable. We're gonna go through everything. No, I'm just kidding. We have a half hour, and I'd like to get to some of the excellent questions from all of our participants. So I think I'd like to start back with Dr. Het-Gauthier, because a couple questions came in earlier that are really quite nice, and they're in your wheelhouse. So do you have suggestions as to how to address promotion policies to embrace equity and collaboration? And I know you do, because I know you've spoken passionately about that. And I will tell our participants that Dr. Het-Gauthier is really a thought leader in this area, and I've learned a great deal from her over the last 5+ years. And so, Bethany, I'll let you talk a little bit about that to everyone.
Thanks. Yeah, I mean, it's definitely an area that we are, and we being a lot of folks who are on this call, both my fellow panelists, but also I see some names in the participant list that I know are chipping away at this. It's for me, it a bit touches on Dr. Jhunjhunwala. You had a quote in yours about the medical mission of this will help with your CV building, and this will help with your future prospects. And I, was oftentimes finding myself being like, well, I need that first authorship, and not thinking about the consequence of me pursuing my needs over, the then residual consequence of my other colleagues and their needs, both, the person down the hall, but also the person across the ocean for my global health work. And so, your question is one that we've given a lot of thought to. The Lancet piece that I had in my slide, we actually outline, that was the product of a 2-day session where we had colleagues from around the world, many universities in the US, but also our collaborators thinking about, what are our pushes and pulls in our professional life that lead to these consequences, and then how can we change them? And so there's some very specific recommendations in there. So one, for example, is from a promotion standpoint, they count the number of first author papers, right? And they will also not penalize me if I'm publishing papers without colleagues and giving them credit. So trying to put in more checks and balances to really evaluate not just the research, but the nature of how we collaborate. And that's not just for global health collaborations, that's for any collaborations and with community partnerships. There's other suggestions there about thinking about our administrative burden. So Harvard does not want me out of Boston for more than 6 weeks a year. But if you try to really address and manifest these partnerships that both Dr. Jhunjhunwala and Dr. Joseph talked about, that's not something that can just happen overnight. It really takes time and trust. And so, that administrative barrier can be a limit to that. So we have specific recommendations. Now the question is, how do you change the policies, and we're doing some efforts through the Consortium of Universities of Global Health to try and have broader position statements, and then really sort of put the pressure on the universities to note that the norms of global health collaboration are changing, and they need to align the promotion policies to that. So happy to share that piece in the chat if that's useful, and you can also just find the title of that paper in the slides.
Thank you so much. And just so that our participants know, Dr. Het-Gauthier has been a very strong advocate for changing those policies even within our own university. And it's not easy. It's a little bit like changing the direction of the Titanic, but she's not going to give up. Just one follow-up question while we're talking about research, because there was another excellent question that came to us about, how do you handle grants with your partners? And, can a PI from another country, can they be a PI on a US grant? And how do you navigate the fairness around funding and who gets what?
I'll start with that and would invite others to chime in. There are some grants for which I am uniquely eligible and not my colleagues, and vice versa. So we really try, and it goes back to that comment around the administrative barriers. So especially pre-pandemic, and we're trying to resume them now, to just be proximate, have colleagues here, maybe there, and spend a lot of our time just brainstorming, what do we want to be working on together? And we have a long list of what we want to be working on together, so that if a grant mechanism comes along that facilitates this common goal, but for which I'm uniquely qualified, I'm not applying because it's my idea for me, I'm applying to facilitate our team's work. And so, there's that aspect of it. The other aspect is, how do we broaden our team's resources, our skill base, our expertise, so that other people can be applying for grants. So why am I qualified for a grant and maybe a colleague isn't? And how do we make sure that in the process of implementing this grant that we're capacitating that person to be competitive for the next one? And so it's always thinking about, maybe you weren't competitive today, but you can be competitive tomorrow. So let's just make sure that we're strategic in addressing that.
Okay, thank you so much. Let's switch to a workforce/clinical question, and actually I throw it to both our clinicians, Dr. Joseph and Dr. Junjunwala. Have an excellent question here from Teo Eganusi. I listened to the aspect of the discussion on brain drain. Will it be fair to conclude that all workers are stolen when some nations do not provide enabling atmospheres for staff to stay in their own countries? So, Dr. Joseph, maybe you can offer a thought there, and then Dr. Junjunwala, you can follow up.
Thank you for the question. It's a great one, and it is a reality. It doesn't happen everywhere, but it happens almost in a systematic way in some places, and I'm happy to give this example. When I was in the latter years of my training, I remember being on call and having seen at least 8 or 10 new doctors from Nigeria. And I was just surprised they were in our emergency department. So I got talking to them and understanding how it came about. There was a national recruitment for Nigerian doctors to come to the UK on a contract for 24 months and build their emergency medicine skills, but with a view to potentially enter into full-time training. So essentially, they're taking those who have the skills from places in need, and that was a systematic program because of the doctor shortages that we have in the UK. So yes, there is a brain drain, but the incentives are so great and high that it's difficult to say no. And I think the other part to that question was, is it because there are issues in their countries, residing countries essentially not stable? So how do you balance that out? Well, I think the answer is you support the systems that are in country to incentivize for doctors to stay. But that's very challenging because what you're really talking about is financial support. And if an individual is to travel from that country to gain the finances that they would to support their countries by working in elsewhere, then are you splitting the difference? It's a really hard question. And ultimately, when you speak to the individual who hasn't been paid for 3 months and can easily move country and earn a lot more money and continue their skills, it's very difficult to say to that person, no, stay in your country and not get paid. We will build the system in time, because long-term partnerships take time to build systems. It does not happen overnight. So yes, there is a brain drain, but there's always a reason to leave because of the challenges with the healthcare system within the countries in which they reside.
Thank you. So, Dr. Junjun, while Dr. Joseph is talking about kind of active poaching, and I obviously think none of us feel good about that, but what about the more passive nature of this, and should high-income countries be erecting barriers so that low-income country providers can't come to high-income countries?
Yeah, I think that's a great question. One of the things that I was actually just scrolling through the Q&A questions, and there's one question that I think I was already going to talk about it, so I'll answer it, which is that, when we say global surgery, this is something that actually the four of us have spoken about many times, and will probably continue to, but global surgery just means surgery, right? Like, it means surgery. It just means people getting access to the care that they need. We call it global surgery because we are modeling it after global health, because people hear things that they know and they reiterate those. But global surgery happens in the United States, and it happens anywhere else. It happens in sub-Saharan Africa, it happens in India, and it happens in the United States, right? So one of the question that I'm alluding to in the chat was that, do you see brain drain as equivalent or kind of related to physicians in the United States not going to rural areas or areas that are under-supported in financial or other mechanisms? And I do think that there is some sort of an equitable relationship there, in that it's really hard to say no when you are working, for decades of your life to train for something that's an act of service to others, and then to finally be given an offer that you think you can't refuse, right? To live in a place that you want to live with your family that you may or may not have been able to live near or with for decades, for your training, potentially to have some creature comforts that you weren't able to have in other places. And, for sometimes what seems like potentially an uphill battle or a thankless situation that you find yourself in. So I do think, Dr. Mayer, like when you were saying, should we erect barriers? I don't know that barriers are necessarily the way to go about things in general. But I do think that there is something there in not only providing financial incentive for the more challenging of these types of jobs or positions, but also being really thoughtful as high-income country hiring practice providers, that who are we hiring and why? But then I think the thing that gets really challenging is who made me the boss. So just because of a miracle of birth, I happen to be born in the United States as opposed to somewhere else, I have now been given the responsibility potentially to choose who does or doesn't get access to the same kind of education and training and opportunity that I have. Sorry, excuse me. But that shouldn't be necessarily the case. So I think my answer is, I don't think that barriers put up by high-income country participants or practitioners is necessarily the answer, but it's more about incentivizing the way that benefits are distributed elsewhere. I don't know if that's skirting your answer, but answering your question.
No, I think that's very true. Lars Hagander, who was one of the commissioners on the Lancet Commission, did some research looking at clinicians who had come, I believe it was to North America, but it might have been to all high-income countries, and did a survey and found that one of the main reasons for folks to leave their home country was just what the participant who asked that question brought up, was that there isn't the local atmosphere, the local community, the local folks to work with. And so I think, on one hand, you're talking about the fact that people have agency and should be able to decide what they do with their lives. And then Michelle was saying, look, but what we should be doing is building capacity and building environments so that people don't feel like they have to leave. So I think, it's not one or the other. And obviously it's not going to happen by tomorrow, but I think the answer is all of the above. Back to research just for a moment. Dr. Het-Gauthier, how do you enter into, in a very practical sense, how do you enter into relationships with your partners so that the authorship is more fair? Because I know that's been something that you've really focused on, and I think it's really important because it's so easy. I mean, I know from personal experience, it's so easy to get working on a paper and you crank it out and pretty soon the authorship is really not very fair. So how do you get started on and get off on the right foot?
It's a great question. I mean, it's definitely, even for me, a continued work in progress, right? Like, I do not pretend like every paper gets it exactly right. And it's complex. So I would say the first and foremost, one of the barriers that I realized I had to this, and it was a bit the point I was trying to make around really trying to understand who you are in this space, was just realizing that I wasn't being honest with myself or my colleagues about what I needed out of projects, right? So, I'm here to help, I'm here to support this research project. And then I found myself clamoring for first authorship without even realizing I was doing it and realizing why I was doing it. And so, for myself, I try to really think about, what do you need? What do your colleagues need? And our teams have 10, 15, 20 people on them. So really trying to balance, now as I'm more senior in my career, oftentimes serving in that PI role where my responsibility is to think about every single individual, what their goals are, what their needs are, what their skills are, and really trying to balance the opportunities for that. We keep a paper list. So as soon as someone comes up with an idea, it goes on our paper list. And the first person who gets priority for that idea is the person who came up with it. It doesn't always pan out that way, but it's a conversation. It's really thinking through, so Dr. Joseph may have come up with an idea, but maybe it was her 10th really good idea. So thinking through, like, what are your priorities on this? And then can we share some of those other opportunities? And it's a constant dialogue. And by constant, I mean, I probably spend 2 to 3 hours a week just navigating authorships and various opportunities. So I think just having open conversation, again, really trusting that you can be honest about what you need and that people can be honest with you, all of that, and then just putting things in writing and really trying to stick to those commitments are some of the strategies we've adopted.
And so obviously the dialogue and the conversation is important. Have you gotten to the point where you have a hard and fast rule and you say, look, I'm not going to submit a paper unless there's, co-first authorship with one person from our shop and one person from over there, or co-senior authorship? Or, I mean, do you get to that point where it's like hard and fast rules, or are you still trying to work through it with conversation?
So I never think of a paper in isolation, right? I think about a paper in the full portfolio of work. So there might be a situation where we have a balance that someone might look at that single paper and say it's imbalanced. Mm-hmm. But I think about it as like the full body of work and, who brings what skills to the table. And some papers, like we do machine learning papers that really rely on an expertise of a colleague at MIT. And so that might have more of his students on it. And then we do papers that are really about clinical protocols, and that might have more colleagues from Rwanda on it. So I don't think about a single paper. One of the challenges I've put to myself is that at least half of my papers have Rwandan first authors. At least half of them have Rwandan senior authors for my papers from Rwanda. So it's more about the full body of work, not a single paper. Right. And I will say there was recently an authorship reflexivity statement that is fantastic. And so I think sitting down and for that paper, thinking about how did I engage partners? How did I think about this opportunity in the context of other opportunities? And that reflexivity statement is actually something that our teams, we're adopting, not just for papers, but for how we go through our day-to-day research. And so I put that link in because I do think it's a helpful reflection for my day-to-day and how I'm engaging my full team, no matter where they sit.
Right. Okay, that's fantastic. Thank you. Dr. Joseph, you talked a little bit about power and power imbalance. Just speak a little bit more to that in the sense that, let's say I go on one of these, medical missions, and I'm all excited. I'm gonna do some cleft lip repairs somewhere. What happens? What do you mean by power imbalance? I show up somewhere, and what happens actually?
Well, one would hope that there was an ask to begin with, and that the need you were trying to meet was a request from a surgeon in country who wanted you to assist in these difficult cases. One would hope that that is the scenario. However, that may not be the case. If it's not the case, then what may happen is you are contacted via an NGO to perform X number of surgeries at X hospital within a very short period of time. You may not be familiar with the hospital, built any relationships with the surgeons, and your approach may be one that is consistent with a HIC facility or OR environment, but is not conducive to getting the best out of people in an NIC or NMIC setting. You do the surgeries, very skilled, but you don't have all the tools that you need because you're not used to working in that environment. So suddenly, where it would have been fairly simple for you, there may be complications, but you have to go back home. You have to get back to BCH. You got to get back to your lists. And also the time difference, so you can't help in real time with all the complications that may or may not occur. So suddenly you're left with this real true desire and need to do the right thing to help, to assist, because with cleft palate, cultural issues, there may be stigmatization with someone who has a deformity. So it's not a unrealistic or inappropriate ask to allow someone to be integrated to society because you have fixed their facial deformity. However, the potential consequences may be far greater than the stigmatization they would have faced. That is a case example of what may or may not occur.
And pushing that a little bit further, Dr. Junjunwala. So, I show up somewhere. What happens in the hospitals in the surrounding region? When I bring a big group of 100 folks down to some hospital, within 100 miles of that hospital, what happens in the surrounding area?
Well, I can actually give you a personal example of what happens. So if it wasn't abundantly clear, the 25-year-old medical student was me that I spoke about. And when I was on that exact trip, actually, people were traveling for miles to come see the American doctors, right? Jokes on them. There was one doctor. The rest were medical students, which, we have our place, but they weren't coming to see doctors. They were coming to see the American team. And not only were people traveling for days sometimes to come and see us, they were also bypassing other clinics and other other hospitals that were in the Central Plateau that were equally able to provide them with care that we were providing, because we were doing blood pressure checks and, prenatal checks for pregnant people. And that's something that many people could have done that they passed by along the way because of the word that had gotten out that the American doctors were coming. And I think I would just say one other thing about power imbalances that Dr. Joseph had touched on. A lot of times you have to think about, and this is something else we were talking about earlier today a little bit, you have to think about what questions you're asking people, because sometimes you might be not asking the right questions. And so when at the start of the same trip, the organization took us, to go see some of the family members or some of the families that we were going to see later in clinic. And they were like, oh, why don't we do a vaccination survey to see how many of these children have been vaccinated? And so, we go down the street and we ask everyone like, oh, have you been vaccinated? And they're all like, yeah, we've been vaccinated. And then I just asked them, one of the kids, I said, when was the last time someone asked you this question? And they said, oh, last week when the last group came. So, there is inherently this system that's set up to not only prioritize the investment that the HIC providers give. And again, not to go back to the same situation, but you see this in the United States as well, right? Some patients want a certain type of doctor. They don't want a doctor that looks a certain way because they want they think that the best doctor is the white male doctor. They don't necessarily think the best doctor is the person who's taking care of them, for many reasons, right? But I think that all speaks to the same concept of being really conscientious about what it means to do a short-term surgical admission trip and ask the right questions about, like Dr. Joseph was saying, I hope there was an ask for you to come do that cleft trip. Is that something that's aligned with the community? And are you actually engaged as a person who is a member of the community also, or trying to help? Or are you someone who is getting the best show possible in order to elicit further engagement? So I think there's a lot of things that come up with that power question that also you might not even realize if you're not asking the right questions.
Well, you hit on something, and I hadn't prepped you for this, but you hit it on something perfectly in that over a decade ago, our team and one of the local teams, I won't say where to give it away, but did a little research project looking at what happens at surrounding hospitals when a team comes to one particular hospital. And it's exactly what you just said, but we also looked at the clinical throughput at those surrounding hospitals. And what happened is the clinical throughput dropped at all the surrounding hospitals because everyone was coming to watch these folks come from other places. So there are definitely some unintended consequences that you have to be aware of. Dr. Het-Gauthier, back to research just for a moment. If you had a magic wand, how would you restructure funding, like from USAID and Gates and Clinton? And how do you make funding so that it promotes equitable research?
That is a hard question. My knee-jerk reaction say, give it to all of our projects because we're trying really hard. But
I mean, I feel like sometimes the funding, promotes some of these issues. And so how would you make the funding mechanism such that it's better? And you know what? I'll throw another part in there that's related. Because you were involved in something in Rwanda. It said, what are some examples of building capacities in LICs and LMICs in lieu of short-term mission trips? Like, who is in charge of the development? So how do we change the funding paradigm around research, but even capacity building, to change the whole paradigm?
Yeah, that question is really the one in the chat, and then I'll get to your question as well, John, really got me thinking. And again, I'm not a surgeon, so I'm not doing these short-term medical trips, but a lot of my early career, I'm a statistician, a lot of my early career was teaching short-term math courses and so doing a 3-day logistic regression course. And Dr. Junawala, I think you were the one commenting on this about oftentimes what I taught, when I taught it, and the sort of the structure of it was all about, well, I have 4 days and I have some motivation to be in this country. And so I'm just going to reach out to the university and say, I can do this. Right. And it was a very specific ask. That is very different now than how now I try to approach it, which is, okay, these are the skill sets that I have. This is the time frame that I have. Is there a value that I can contribute? What are your needs? So I work a lot now with the Africa Center of Excellence in Data Science. What courses are coming on your curriculum? How can I help? And sometimes they just end with, you're not useful to us now, right? And that is a perfectly fine thing for someone to say to me, your availability and your skill sets and your goals don't match with our needs and our priorities and our infrastructure. And I have a long-term friend and colleague, Janine Chanda, who just always reminds me, she was at the University of Rwanda. We spend so much time bowing to the goals and the priorities of the people who are coming to teach 3-day logistic regression courses that we never teach our survival analysis course because we're just doing these other courses. So I think there's a parallel there to the surgical mission trip, right? And how those are approached, right? I think there are, for those of you who are on the call, I think there are still opportunities for, if you have 2 weeks and a very specific expertise, I think there are opportunities for that, but it's about doing it in a way that's not orthogonal to systems and to programs and finding the right way to do that. So to your funding question, I think there's a direct line to that, right? So if my colleague wants a survival course, don't just say that you're only going to fund logistic regression, right? Or if my colleague wants a 2-year training, don't only give funding mechanisms for 6 months. From the research perspective, I always call it the butt and chair metric, right? Funders want more butts and chairs. They don't want better and deeper trainings and partnerships. So, I think those are things that come to mind with funders, but I definitely think funders need to start adopting, that reflexivity checklist that I think is going to be shared with you. They should be asking grantees to be reflecting and really demonstrating their intentions in the application.
Right.
And that should be an evaluation criteria for sure.
Thank you. That's great. Dr. Junjunwal, go back to you again, because you brought up the issue of the 25-year-old going down there. I've seen a question or two relating to, is it, even ethical for us to be going over down these short-term missions? And I'll make it more for med students, because, why should we be sending a North American med student anywhere? How do they help? What value are they on any type of a mission trip?
Yeah, so I would say we shouldn't. And that was the only mission trip I went on. And I had such a bad taste in my mouth afterwards from kind of everything, how it all went, that I really threw. That is actually one of the reasons why I chose to do my master's in ethics, because I knew I had these big questions. And as Bethany mentioned, Dr. Hegathi, I mentioned a moral obligation. I felt that moral obligation to do more, but I didn't know the best way to navigate that for myself. And I think there was another question in the chat about, is there other ethical frameworks rather than Beecham and Childress that you could, apply to these types of questions? And that's what I wanted to learn more about in doing that master's program. And so I would say to medical students, it sounds very fun to go somewhere and do something and maybe learn how to do a technique that you wouldn't be able to see somewhere else. But I would posit that there are places in North America that you can get the same experience and probably way closer to home than you think. And I actually got that question a lot when I was applying to surgical residency. I went to medical school in Atlanta, and there are lots of disparities within the city itself. In Boston, where I'm located now, there is, a lot of evidence for life expectancies dropping once you cross a road from Mattapan to Milton. That is not unique, right? It's not unique to Boston. It's not unique to Atlanta. It's true for pretty much anywhere that you have a city with people. And I think that the advice I would give is to really re-examine the reasons why you want to do that short-term surgical mission and why you want to go to Uganda or Rwanda or Haiti rather than down the street. And if your answer is that you want a trip, you should just take a trip.
Right. Well, I think people agree with you. I've seen a couple comments in line with that. Dr. Joseph, I've noticed a few comments and questions here about how do you use technology, telemedicine, et cetera, et cetera. Is that a way that can help us, establish better longer-term relationships or help with equity? I mean, how do we use new technology to do this better?
I think if COVID has taught us anything for us that are working in the global health and global surgery spaces, that there is work to be done that can be done remotely. And if you can capitalize on the technology that's available to you, while also being able to be utilized by our partners in the countries in which we work, I think it's important for us to really harness technology, not just in communicating, but also in training as well. What does it look like to be able to deliver training remotely? How do you push the boundaries of what currently exists? I think one company which us at the program Global Surgery and Social Change are familiar with is Proximy. Being able to deliver training in theatre in real time without having to be in country is really pushing the boundaries of technology, but also allows us to have more of a hands-off approach while still ensuring that training is being delivered in an effective way. I think more of us need to start using technology to the advantage of our partners rather than to the benefit and convenient of ourselves. If we shift our lens, I think we're able to push the boundary further. Another thing I'd like to mention is the Intuitive Foundation, who are currently working on really being a disruptor when it comes to training, allowing access to those who typically wouldn't have the benefit of going to medical school, being in those circles, but being able to identify that they're bright enough to learn surgical skills and become surgical officers in the countries in which they reside by having the material readily available. Now, there are a whole bunch of ethics around that. You don't want anyone, random person, doing surgery, but there's an opportunity here for us to bypass the traditional route in order to ensure that we are training up the numbers that are required in order to deliver the surgery that is needed in these spaces.
All right, well, gosh, we have 3 minutes left. So just in the short time that we have, maybe in the order that the speakers spoke, maybe I'll let each of you just offer a few final comments, or if there's a specific question that you really liked that I didn't get to because there were so many fantastic questions, go ahead and answer that. But so Dr. Het-Gauthier, if you have just a comment or two, or you want to answer a question that I didn't get to, please go ahead.
I mean, there's so many great comments in the Q&A and questions, but I just want to express gratitude for this space. And I've known Dr. Mir, Dr. Gingerwala, and Dr. Joseph for a long time. And I think part of why I'm getting better, and again, not perfect, is just having these conversations. And so to Dr. Kanto and the team, just having this space and really pushing us to think more about this. I think it's so important to have these conversations, and hope you continue it offline after these sessions for those of you participating.
Thank you. Dr. Joseph, a comment or two or a question that you wanted to answer that I didn't get to?
Well, first of all, I'd like to share my thanks as well. It's a real opportunity to share the panel with colleagues, but also to read all the fantastic questions in the chat. There are so many that I would like to answer, but one that really stands out for me and I think is important is there's not one framework that fits all. In an ideal world, you could have a 4-point system and apply it, but that's not the reality. These are nuanced and complex problems, and complex problems require complex solutions. So it's important for us to take things in the context of the circumstance rather than utilizing some frameworks only. There was a question regarding are there any other frameworks out there, and I would suggest the application is very much dependent on the circumstance.
Thank you so much. Dr. Gingerwala.
Yeah, I guess I'll just speak briefly as the trainee on the panel. I would encourage all of the medical students and trainees who are here listening to really question or undergrads even, anyone who's thinking about a career in surgery and is motivated by global health. I would just think about ways to show your commitment to this space and this work without having to feel like you need to be traveling somewhere that's, as Dr. Audra says in the chat, Instagrammable. You don't have to. And if you can show your commitment to the communities that you want to actually work with and in, that will come through. And I think it is important for us to keep that moral compass, despite what we might be swayed by, because the same pressures that exist when you're a medical student or an undergrad are the same pressures that Dr. Het-Gauthier was talking about that push you to try and achieve something for promotion down the line. And I think I personally am just working on practicing staying true to myself and my moral compass on that. So I would encourage you to do the same.
So first of all, I want to start out by thanking all the participants for spending 90 minutes with us. That was a commitment, and I hope it was enjoyable. I'm seeing some very nice comments, and I appreciate everyone's comments. Secondly, I want to thank our 3 speakers. They put a lot of time into those talks, as you could tell. They were new lectures that they put together, and we really appreciate what they did. And then I want to thank the HMS Center for Bioethics. That fantastic venue. It's really an honor to be able to do this with all of you. So with that, I'll hand it back over to Dr. Kanto and the crew. And thank you so much. This was really a wonderful opportunity.
Well, I'd just like to reiterate Dr. Mir's thanks to Dr. Het-Gauthier, Dr. Joseph, and Dr. Gingerwala for excellent presentations and discussion, and also particular to Dr. Mira for moderating the discussion and doing a great job getting to many of the questions that were in the chat room. And also thanks to all the participants and the questions. As Dr. Mira has indicated, the feedback we're getting so far is that people did really enjoy the presentations, learned a lot about global surgery and some of the challenges that have been brought up by the speakers. So we'd just like to reiterate our thanks, and thanks to the Center for Bioethics and their staff, Ashley, Helen, Kyle, for their work in making this technologically work, and for helping us learn how to manage the Q&A. We couldn't have done it without you. So to all the participants, we look forward to hopefully seeing you next week. On Monday, we will have our session will be ethical issues in gender surgery. And the moderator of that session will be Christine Mitchell, who is the executive director of the Center for Bioethics. So we hope to see you all here next week, and Godspeed. Good night.